Good afternoon, everyone, and welcome to the ASTCT Town Hall webinar on COVID-19. My name is Kira Newman, and I'm the Senior Coordinator for Education with ASTCT. I want to thank you for taking the time out today to join us and discuss these current pressing events. I also would like to thank our speakers today, Dr. Pavan Reddy, who is the ASTCT President, and leadership from our ASTCT Transplant and Infectious Disease Special Interest Group. It's Dr. Alpana Waghnare and Dr. Chemaly. Thank you all for being here today. These folks have been key with our leadership and leading the discussion and development of what we're going to be talking about today. So I'm very grateful for you taking the time and lending us your expertise and guidance. Just a little bit about logistics for the webinar today. The slides and recording of today's webinar will be distributed and posted to the ASTCT COVID-19 community page. We'll be providing links and information on how to access that at the end of the webinar. There will also be a section for question and answer at the end of the webinar. If you have any questions throughout the presentations, please submit them using the GoToWebinar panel on the right hand of your screen as seen here on the slide. If we are, for whatever reason, unable to answer your question during the webinar, you may email us at info@astct.org or post your questions to the COVID-19 community page. We will be sharing the link to that during this presentation. At this time, I would like to hand the webinar over to our ASTCT President, Dr. Pavan Reddy, who will discuss the agenda for today, as well as an overview of the current landscape in the United States. Dr. Reddy?
Thank you, Kara. This is Pavan Reddy. Thank you all for joining us and welcome. What I'm going to tell you is just quickly take you through what we are planning for this webinar, and then we'll leave 15 minutes or so towards the end for any direct questions. And some of you have already submitted some questions, which we will hope to answer before we take some of the direct questions. That said, I think for the agenda today, I'll just go over briefly the current landscape here in the United States as it relates to COVID-19. And my fellow panelists, Roy Chemaly and Alpana Waghnare, will go over some of the ASTCT guidelines, which they worked so hard with others to put together, and it's fantastic given where we are and what we know so far. And then we all three of us will discuss the implementation at individual facilities just to get the conversation going, and then we'll open it up for all the Q&As thereafter. Next slide, please. Thank you. So far, this is data as of March 22nd. Obviously, these numbers are growing somewhat exponentially. As of March 22nd at 4 p.m., the total number of cases in the United States is 33,000 with over 400 deaths. And to the extent the sources of exposure were figured out, travel-related were about 449 of the 33,000 odd, and close contact was 539. Under investigation as yet at this point in time is the rest with 32,400 odd cases. Again, these numbers will look very different if you just looked at them right now on the website. So on the right side of the panel is the COVID-19 cases in the United States from the date of illness onset with the starting point of January 12th of this year, and the end point I just said is March 22nd. As you'll see that the number of cases have been going up per day, and illnesses that began during this time in the last 14 days obviously have not been reported, so those bars will look much higher when that comes in. Slide, please. The ASTCT guidelines were put together by the Transplant and Disease Special Interest Group from our society, and these guidelines were developed in real time with a lot of input from other members, but Alpana and Roy have been spearheading this, and they've done an unbelievable amount of work to get them up and going. And there's a link on our website, these guidelines, for those, many of you, to follow it in real time. They would be adjusted and modified as more data comes in. With that, I welcome Alpana Waghnare and Chemaly to take us through some of the high points of the guidelines. And the next slide, please, Karen.
Great, thank you. This is Alpana Waghnare from Fred Hutchinson Cancer Research Center. Thank you all for attending. Thank you, Pavan, for setting the landscape. I would like to thank all the other members of the Infectious Disease Special Interest Group through the ASTCT that have contributed to these guidelines, and thanks to the EC Committee for supporting us as we put together these guidelines, and as Pavan mentioned, continue to update them as new information comes forward. I'll start with just a few of the diagnostic considerations that we've outlined in the guidelines. So our current recommendation is for any HCT recipient or immunotherapy patient that we would recommend COVID-19 or SARS-CoV-2 testing in any patient that has respiratory symptoms. And we initially had said in specific circumstances of exposure, but given widespread community transmission, we would consider this for any patient if testing is available. The collection methodology continues to change as both the CDC and FDA continue to make adjustments to testing recommendations. So we recommend following CDC and FDA guidelines for swab collection. We do think, however, that that nasal sampling has a lot higher yield than any oral sampling, so we would recommend ongoing nasal sampling. And finally, though the centers will vary on their methodologies for nasal sampling, if possible, we would avoid doing a true nasal wash given the potential for transmission of virus, but we understand that that may change as at any given center and or as swab availability becomes potentially an issue. Next slide, please. In patients that are positive for SARS-CoV-2 in an upper respiratory sample, we would recommend considering chest imaging. We don't think it's a hard recommendation given that there are specific considerations about infection prevention and moving patients throughout facilities. So it should be considered, but it's not absolute. If SARS-CoV-2 is not detected in the upper respiratory tract, we do recommend considering that a patient may have lower respiratory tract infection, even with a negative test in the upper tract. There have been descriptions of patients with only lower respiratory tract disease, and if a patient has concerns for lower respiratory tract symptoms, including shortness of breath, hypoxia, tachypnea, we would recommend considering a lower tract infection. Next slide, please. We do not recommend routine bronchoalveolar lavage to assess for lower tract disease, again, because of infection control and infection prevention concerns. However, given our patient population and the level of immunosuppression that many of our patients have, we would consider it if there is another indication and or concern for a co-pathogen that should be diagnosed through bronchoalveolar lavage, in particular bacterial or fungal co-infections. We will go through some of the testing recommendations for HCT and immunotherapy candidates in the next slide. So in candidates, for any patient with symptoms of an acute respiratory tract infection, they should be tested for SARS-CoV-2. At our center, we are recommending that in addition to multiplex PCR, given that there have been reports of co-infection, the exact percentage of patients that are co-infected with other respiratory viruses is variable in different reports, but there is potential for another respiratory virus to be identified. In particular, we would worry about influenza, where we do have a therapy that we would give if positive. The second point, if SARS-CoV-2 is detected in a respiratory specimen, we do recommend consideration of delay of transplant or cellular therapy procedures. In the document itself, there are several considerations that have been outlined in terms of when deferral should be considered and when it is not necessarily an option, depending on the disease status of the patient. And then finally, in patients that have, or candidates, excuse me, that have had a close contact with an infected person, we also recommend delaying therapy for at least 14 days, but preferably 21 days from the day of the last contact. Next slide. Initially, we had recommended specific areas to avoid for travel for candidates, but given, again, widespread prevalence of the virus, there's just non-essential travel should be avoided altogether. At our center, we are recommending that every candidate, HC2 or immunotherapy candidate, does undergo testing for SARS-CoV-2, even when they're asymptomatic, prior to the initiation of therapy procedures. We have 2 time points that we're recommending. Once initially at the time of initial evaluation or arrival, as we refer to it at our center, and then additionally 2 days prior to initiation of conditioning and or lymphodepletion. And again, this would be regardless of the presence of symptoms. We can go through this more in the question and answer period, but if possible, for many conditions, we are recommending that considering deferral of therapy or consideration of other interim treatments should be considered if feasible. Next slide, please. For donor recommendations, this is a changing landscape, but we're using guidance from the NMDP as well as the AABP for recommendations. But in general, if a donor is positive for SARS-CoV-2, they are considered ineligible. However, that doesn't completely preclude them from donation under certain circumstances that are outlined again more specifically in the guideline. If a donor is in close contact with a person diagnosed with COVID-19, they should be excluded for donation for at least 28 days. Again, I refer you to the current NMDP guidelines for updated guidance on unrelated donors. The latest status is for that all unrelated donors should undergo cryopreservation. There are some recommendations of looking for alternate stem cell sources if available, and choosing donors without risk, although we realize that's difficult at this point. And then donors within 28 days prior to donation should practice good hand hygiene and avoid crowded places and large group gatherings. This, of course, is quite variable throughout the country, where there are different levels of restrictions for these travel and or shelter-in-place recommendations. Next slide, please. Okay, with that, I'll pass it on to Dr. Chemaly.
Thank you, Alpana. Good afternoon, everyone. Thank you for the opportunity, to be part of this WebEx. So I'm gonna talk a little bit about what are the treatment considerations for our patients who are gonna have if they're gonna have confirmed COVID-19 or SARS-CoV-2. Someone reminded me today that we're relying now on anecdotal data or some experience, not even published data. So I want to caution everyone, there is lots of publication out there or data out there talking about different therapy, different regimens. So be cautious, look very well at the published data, look at the design of the trial, what they did, and the number of patients they treated before you make a decision at the local level what type of treatment can be used. and unfortunately we don't have that many, but it's all mainly based on either small sample size or anecdotal data. But what there's just some general recommendations here where for us, at least for asymptomatic patients, we're not treating, we're not recommending any therapy. Now, if there is a clinical trial available for any of the conditions, probably enrollment into trial will be a priority. There is a talk about maybe prophylaxis trial or for asymptomatic positive patients, but it depends on the availability and the access to the trial. If someone has only upper respiratory tract infection, meaning they have no evidence of pneumonia or lower respiratory tract infections by either X-ray or CAT scan, also treatment really is not recommended to whatever options we have available with. But again, if a clinical trial is available, this is our recommendation. Now, between someone who have LRTI without oxygen requirement or someone with severe infection, meaning now they have LRTI but they require oxygen or even mechanical ventilation. So I'm going to go over a few options that we are recommending. That's something that you probably need to look at. Next slide, please. So we didn't actually, on purpose in the guidelines, we didn't really list by priority which drug need to be used, which one to start first, because it's a moving target and we're learning on a daily basis different data coming out, and we're learning about, looking at different processes. But we wanted to list what's been used already and what drugs have maybe in vitro data or may work against this SARS-CoV-2. The first agent listed here is remdesivir, which is undergoing multiple clinical trials in the nation and worldwide. If you have access or you have it at your site, this could be an option to enroll patients on this trial. To my knowledge, as of yesterday, I think Gilead they probably limiting access to compassionate use, going to be more expanded use access. So it will have hard time to get remdesivir for our patients probably from now on compassionate use. But if you have the trial available in your site, so probably this way be one way to go to enroll your patients. But they have very specific criteria for enrollment, at least one of the trial looking at really sick patients already on mechanical ventilation. The other option that we may be able to use if we have access to, because there is some shortage that I heard of, it's chloroquine or hydroxychloroquine. There is some in vitro data for both formulation of chloroquine for other coronaviruses, including SARS and as well as MERS. But also there's some clinical data coming from different countries about using either one of these compound or drug in COVID-19 patients with severe or non-severe infection, and with some showing it could have some antiviral effect and affecting outcome. But I will also caution you, it depends on which trial and what kind of design that you are looking at. I don't think we have the answer yet if it is a good treatment for our sick patients with COVID-19, especially when the experience in our stem cell transplant recipients, it is very minimal, if not also lacking. There were a lot of talk about ribavirin, especially in the past for MERS or SARS, which is the CoV-1 as well. In theory, it may work. I'm not sure if something we need to consider as monotherapy or maybe combination therapy. And for any of these drugs, we talked a lot about, which route to go. Is it we're going to use a combination versus monotherapy, especially in view of some of these drugs could be in shortage or no access to. Now, tocilizumab in someone with severe pneumonia with probably cytokine release, syndrome, or with ARDS, would does it have any impact on outcome or not? Also, this question need to be answered, hopefully in clinical trials. But we know that some providers, clinicians used it in severe cases, and some claim that it had good outcome in some of their patients. But as I said, most of this experience, if not all, were not in cancer patient or patient with hematologic malignancy or after hematopoietic cell transplantations. What we're recommending is, again, the use of corticosteroids or IVIG. We know that steroids usually are a major risk factor for progression or for worse outcome in our the transplant patients based on data from many cohort studies looking at other respiratory viruses like RSV or parainfluenza versus influenza. We know that steroids are really not a good players here, but when you have very severe ARDS, would it have a role? We don't know, and that's why we caution the use of corticosteroids in our patient population. IVIG, the same thing. First, there is a shortage nationwide of IVIG, but also if relying on antibodies, concentration against COVID-19 or against SARS-CoV-2, you're not gonna find most probably in most of the IVIG formulation. So it may not have an impact or effect on our patient with severe infections. Don't forget about antibiotics. Our patient may get superimposed bacterial infection, although it's not well defined yet. We don't know how many and how, when, but something to keep in mind that we cover sometime with antibiotics, maybe also antifungal. I'm not sure, like influenza, we have some data showing after influenza infection, the rate of pulmonary aspergillosis may go up or not. So something also to keep in mind, and I would take it case by case, depend on the patient, the time from transplant, and other comorbidities can happen. And the last one is lopinavir, ritonavir. We were a little bit more excited about it maybe 1 week ago until data clinical trial was published showing probably no impact when you compare to other modalities or to placebo. And that's why probably now people are thinking twice before using Calitra or lopinavir, ritonavir at that point. Does it has any role in combination? We don't know. So that's why probably now we put it in italics, but something that had been used, that was tried in China and other countries as well to treat patients with COVID-19. With all these drugs, I want to caution you, they have they can have serious side effects. Be careful with QT prolongations for chloroquine or hydroxychloroquine, especially in addition to other drugs, can prolong QT and maybe other serious side effects as well. So they're not benign, any of these drugs, that we have to keep a close eye on our patients before and making sure that we're not creating more harm. The one thing that I didn't list here is azithromycin, that most of you probably heard of this small studies, lots of issues with these studies, with it, and I'm not sure as of today is it really something that we need to consider based only on small number of patients and only on viral load data and not even outcome data that I would like to see with the combination of azithromycin with hydroxychloroquine. So also something that probably you heard it a lot either on the news or you saw the publications. Next slides, please. Okay, so this is my last slide. I will give it back to Pavan.
Thank you, Roy. What we'll do now is we'll have some discussion amongst ourselves about implementation at our facilities to get the conversation going. And remember, this is supposed to be like a town hall, so feel free to chime in your questions, and then we'll answer them in the order we get them after answering those that we've already received. So Roy and Alpana, I think, can you guys hear me well?
Yes.
Yes.
Okay. I think one of the questions that all of us are grappling with, I'm sure at the other centers as well, is the question of delaying transplant. And one of the key questions is if we are delaying transplant, what type and when. And maybe I can just take that from what we're doing at Michigan, and then Roy and Alpana, you guys can chime in from your respective centers as well. The short answer is yes, we are actually delaying all what we call non-urgent or non-urgent transplants, which is most of autologous transplants. Most at our center are down for myeloma typically, and a few for lymphoma, but largely myeloma. And then we are actually postponing even allotransplants for intermediate risk MDS at the AML as well. But the transplant we're not delaying are the high-risk AMLs or active blasts at the time of transplants with a certain less than 5% is what we typically do. And in cases where we cannot truly delay transplants because of patient conditions or in some cases the donor situation. So the short answer is yes, we are delaying. Our numbers are down by about 35 to 40% as of this week. So I think that's where we are. And Roy and Alpana, do you guys want to chime in what you're doing at your centers?
Yeah, I think that's generally aligned with how we're approaching it as well. We have a little bit more granularity that we established at our center for exactly which conditions. And then if there's any questions, these are also reviewed on a case-by-case basis to decide whether delaying is an option, and heavily weighted towards delaying if possible.
Yeah. And I would say we're doing the same thing as you both mentioned as well here in Houston.
I guess the only thing I would add is that for immunotherapy in particular, I think there have been a lot of discussions as well, but that we are also postponing any trials where the clear benefit has not been established yet.
Yeah, I mean, I think it sounds like the general approach at most centers has been to delay all non-urgent transplant. I don't want to say non-essential because I don't think there's any transplant that's not essential. I would say non-urgent transplants. The other question I think most of the centers are grappling with includes testing transplant recipients for coronavirus prior to transplantation. I know, Alpana, you've mentioned that you are testing everyone at your center now, regardless of symptoms. And I can say at our center, we were not testing patients who did not have symptoms until this week, this Monday. And starting this Monday, we are now testing everyone just because I think the prevalence in Michigan's been really shooting up, and we figured we might as well test everyone regardless of symptoms. Roy, what's going on at MD Anderson?
Yeah, actually, we also started testing asymptomatic patient before transplantation just recently when we validated our in-house testing, and with the caveat that as long as we have enough test capacity, we're testing all patients before transplant, a few days before transplant and admission for conditioning. We moved to that decision when we start seeing community spread of this virus in Houston. So at that point, that's what we are doing as of today.
Yeah, I mean, there's obviously hard times, and I think most of our practices are still fairly aligned, it sounds like, at this point in time, which is great. And other question that most folks tend to wonder, pragmatic thing, is what do we do with donors? Do the products need to be cryopreserved, and which donors cannot be used? I think our guidelines are fairly granular on this one, and we pretty much adhere to what's on our guidelines. But Alpana and Roy, do you guys want to sort of jump in on that one? I will generally say that we are cryopreserving everything now, match-related donors as well, and NMDP has already suggested we cryopreserve all of the unrelated donors. But Alpana and Roy, thoughts on what you guys are doing with donors at your centers, and how you're managing things there?
Yeah, for at least for us, for now, we cryopreserving the match unrelated donor, the match SIB, and the haplo identical for now. So yeah, almost some of the product are cryopreserved.
Yeah, and here the majority will be cryopreserved. I think there's a few exceptions for fresh, but
right. I mean, which brings up the question. I know that so far the FDA recommendations are, or at least FDA hasn't suggested, or no data to suggest rather, that COVID-19 can be transmitted through blood products. But Alpana and Roy, collective thoughts on any donors that cannot be used at all, or should be delayed in terms of, I know we have some, it's really fairly granular on our website, but for those who are listening, if you guys can just chime in on which donors cannot be used or should be delayed in using them.
Yeah, I think the possibility that there's blood transmission of the virus is exceedingly low in anybody with certainly asymptomatic disease, but also probably in mild disease. For other respiratory viruses, when we have looked in the blood, it's really only in those patients that are severely ill, usually requiring some oxygen support and or mechanical ventilation, which precludes them probably from being a donor regardless. So I don't know, Roy, if you have any other thoughts, but I think that's our general framework for thinking about donors that might be infected.
Right, and this is also in the guidelines, but I would say, we need to still remembering that this is a respiratory virus. We don't know really how much of systemic spread is happening, but based on our experience, all the respiratory viruses, it's very uncommon, even with serious infection, to see even either viremia. There is, few data I know, from Michael and Alpana's group looking at PIV in the blood or RSV, but it's not common. It's very uncommon, but we don't know with this virus yet. That's why we were pretty cautious when we were recommending, for donors, if they had exposure, any risk factors, not to donate for at least 28 days, or, especially for asymptomatic. And for the one who already have the infection also, we have to be a little bit more careful. As we learn more about the natural history of this virus, probably we can have different recommendations in the future. But for now, we have to be more conservative with donors for now, if we can afford that.
Yeah, I mean, I think that just has been the general principle at most places, it sounds like. And again, your thoughts on what do we recommend for family members and caregivers of COVID-19 transplant patients? I think most of our patients are generally quarantined from, or the family members self-quarantine if they're some sort of sniffles, or even in the pre-COVID-19 era, which seems so long ago, it's just barely a few weeks. But so any thoughts on any specific recommendations or guidelines for family members, caregivers that you guys are utilizing at your centers? At our center, I can say right now it's fairly loose. I mean, we generally use the same criteria we're using for donors to say anybody who's been traveling around. This is, again, changed now at Michigan, so I think it's sort of moot. But anybody who's been in direct exposure to known COVID-19 patients, if they're symptomatic or asymptomatic, they take themselves out of the caregiver lineup for a month or 4 weeks. And then anybody with any kind of upper respiratory tract illness is generally exempt from providing care. for our transplant patients. Alpana, Roy, any other specific precautions you guys are recommending for folks at your centers?
I can tell you what we've been doing here in Houston. We start limiting visitors and caregivers coming to institution. We start with 2 per patient, then 1 per patient, then 0 per patient started this week. And for any patient coming, except with some exceptions for our transplant patients, for caregivers, maybe 1, but not more. Now, let's say if we have COVID patients already admitted, a transplant or not, there's no visitors allowed, no family members allowed to be in the room or in contact with the patient if they are positive. And we ask family members to stay home for at least 14 days, actually, because they could have been exposed if their loved one had COVID-19 confirmed. So they stay home. They don't even come to the institution for 14 days, checking their temperatures twice a day, and they're positive, and they start having symptoms, they have to go and be tested for COVID-19. So we're taking probably kind of measures for now as soon as we start seeing more community spread. So we're limiting visitors down to 0, except for special situations where we're allowing 1 visitor if we have to, but we're limiting traffic and visitors. So this is our approach as of today in our institution.
Yeah, I guess, I mean, generally also in line with that, in our hospital overall, there's now a no visitor policy altogether. So inpatients, even family members are not allowed. So I think, it's a changing recommendations very rapidly, but that's where we are. I guess I would add one more thing about clinic visits, and I don't know if we're going to talk about this later, but at our center, we have had several discussions about moving several clinic appointments, if possible, into telehealth. So for anything that doesn't require, a patient to physically come in, they're actively working on setting up processes for telehealth for those clinic visits.
Yeah, no, that's a good point. I mean, we have actually gone telehealth in the last 2 weeks. And I mean, across the board, not just transplant patients, but all oncology and hematology patients as well. But yes, that's true. I think about half, not nearly half, I would say about 35% right now are managed telehealth. I mean, certainly the ones that are more than 100 days out from transplant, vast majority of them have been converted, at least at the moment, into telehealth clinic visits, which remains to be seen how this all shakes out as things start to evolve more. For now, yes, that's a great point, and we have been trying to leverage telehealth fairly rapidly as well at our center. It was initially sort of not a go-to choice for many of our doctors, but I think under the circumstances, that's sort of seen a huge surge in utilization. In fact, we had a thing crash last week just because so many people got onto it and are trying to do it now. But it's back up and running. I think that's great. One other quick question for folks listening, and probably would like to hear from us, is how are we managing in the context of resource crunch and resource preservation, and particularly with supply chains being affected, and as many of us are now probably facing the possibility of having fewer blood products to give. Are the centers doing anything specifically? I can say at our institution, bone marrow transplant and cell therapy is the highest priority. So far, we have not been asked to make any recommendations to our usual practice, but this might change in a week or so. So for now, I think we are okay on that front, but also the fact that we've reduced our number of transplants our utilization of blood products hasn't been as it typically was before all of this started. What about at your place, Alpana and Roy?
So for us, actually, we are more stringent with blood products across the institutions. We didn't differentiate between transplant, leukemia versus solid tumors or other cancer type. But what we did is lower our threshold for transfusion blood product like red cells for hemoglobin less than 7 and platelet less than 10,000. So we lowered the threshold for transfusions. So that's how we try to save some, to prevent or preserve our blood product. And we did a big internal campaign for blood donations from our staff and for the community, because this is an issue where we were really worried about, and we are still worried about the shortage of blood supply or blood product supply. So we're working pretty actively on that, try to preserve what we have for our patient who really needs it, in most instances.
Same here. We also reduced or lowered the transfusion thresholds as well.
Okay, so I think in the remaining time, we've got about 20 more minutes here. I'll quickly, some of the questions have been submitted, and if more questions are coming in, Kara, if you could just send them in to us. But let me go through some of the questions I think we've already addressed in the implementation section. But one of the questions, Alpana, I think if you could take this one, was the health worker PPEs and also the use of PPE for when taking care of asymptomatic patients, and the test for COVID-19, should it be a COVID-19 only or a multiplex viral PCR is good enough as well. I think I have my thoughts, but Alpana, what are your thoughts on this?
Yeah, I think the healthcare PPE is a tough question for sure. Again, I think the landscape is changing rapidly. We are not having healthcare workers wear PPE around asymptomatic patients right now. And then for the who and when to test, I sort of as in line with what what's in the recommendation, but we're testing anybody with respiratory symptoms, and then the asymptomatic candidates at the 2 time points, as I mentioned. I do think that the multiplex PCR, if possible, is important to do along with COVID-19, but I recognize that there are issues that might be center specific about whether a separate swab is needed, et cetera, and limited resources to be able to do that. But in an ideal world, we would recommend doing multiplex PCR in addition to COVID-19 testing.
Can I ask you what the turnaround time is for the multiplex PCR?
So ours is a laboratory developed test that we use. So it's about half a day, but I know a lot of centers are using commercial assays that are like the BioFire, which are much faster, so within 2 hours.
Right. And Roy, your thoughts on, one of the questions that we received is, are there any clear criteria for what constitutes close contact with a proven case? How would you define a close contact is the question, Roy?
Yes. So, this is a good question, because even the CDC, they're a little bit vague about that, the close contact. And this is very important now when you start seeing community spread of this virus, and now you have confirmed cases, you have to do contact tracing and how you define exposure. So what we're going by is, person being within 6 feet of the infected or suspected patients or person, and for more than 5 or 10 minutes, it depends, it's very arbitrary, but more than few minutes. That's how the CDC put it out there. So for us, we went by 5 minutes. So if you've been in contact with this person who tested positive and you're exposed and you've been within 6 feet with no appropriate PPE at that time. So this is important for an employee because you always have suspected and you're wearing appropriate PPE and now it's confirmed, is it exposure? It's not exposure because you're wearing appropriate PPEs, even if it's surgical mask with eye goggles, eye protection, that's fine, and with the gowns and gloves. So this is the usual definition, but I'm sure every center has a little bit different, but it has to be pretty close contact for more than a few minutes, I would say.
Great. I mean, I think there's some questions coming in already. So let's quickly cover some of these other questions that we received early on. One of the questions, are there any difficulties regarding N95 mask supplies? And in Brazil, and many healthcare workers don't have them. I think in the U.S., so far at our institution, we are trying to preserve what we've got. Again, the hospital and ethics committee have sort of prioritized where this mask would go. At the moment, transplant and patients and caring for those who are caring for transplant patients are in the most urgent category. So I think our own unit hasn't faced it at this point. That said, I think one of the other questions that actually came in live, I think that somewhat relates to this. I'll club these two. It says testing kits at this time are limited. What kind of screening do you recommend in these kind of situations? Alpana, I mean, in our case, I mean, I think for the donors, we just postpone them by 28 days where we can, if we can test them, but it's really not been more recently an issue with our own in-house kit going live about 10 days ago as well. But Alpana and Roy, any thoughts on any specific recommendations if the test kits are not available, what you would recommend, particularly if they're patients, I guess?
Yeah. So,
yeah. Go ahead.
Okay. So testing, it's still in shortage, and even if you have the available platform that most centers may have it, but the reagents, the kits may be in shortage and not really available, and the capacity of running testing is limited. So that's why we have to preserve these tests, these assays for symptomatic patients, I would say first. This is the priority because I want to know my patient who's admitted or in the emergency room, do they have COVID-19 or not? Because then this will affect management maybe, or affect infection control and many other issues or the trickle-down effect. So I want to make sure I protect my assay or protect the capacity to run this assay for these kind of patients. Now, if I have enough and if it's coming online more assays and more, and especially with the reference lab, then I would say a symptomatic patient before transplant could be a way to go. If I have only limited, maybe then we have to pick only the higher risk transplant, a patient going into transplant. Maybe these patients should be tested and not the low risk if I cannot delay their transplant. Maybe it could be allos versus auto in the future if we don't have access to these testing as much as we want. So I would say priority for all of us, and because we're getting lots of questions about, I want to test all of my patients with leukemia or all my patients with lymphoma, even if they are asymptomatic. I want to know. But first, we have to be careful with testing. You can have lots of false negatives if someone is symptomatic in the incubation period. No one knows how many you will pick up asymptomatic patient with COVID-19 on the testing available for us. So false reassurance that your patient is negative. But at the same time, I want to preserve these tests for my symptomatic patients. I want to confirm it because I may need to put them on trial or treat them or do something about it, and from infection control purposes as well.
Yeah, I think that.
Yeah, I agree.
Some of the quick questions here, and let me actually pull in some of 2 or 3 together. Alpana, could you take a crack at these questions, like the diagnostic symptoms, respiratory versus gastrointestinal, and also briefly mention, as we were talking about a little bit earlier, in terms of any databases being available at this point in time. If you could quickly answer those two questions together.
Sure, yeah. So from the data that I've seen coming mostly out of the large data sets or large cohorts of patients out of China, by far, I think respiratory symptoms are much more common than GI symptoms. There was a description of a small number of patients, I think less than 10%, that had GI symptoms before the onset of their respiratory symptoms. But again, by and far, I think the respiratory symptoms are much more common. So I would just use caution when just considering GI symptoms as a possible diagnosis of COVID-19. And then in terms of the compiled data, so as you all probably know, there's limited data that we've seen yet in our patient population out of China and the other countries that have been more severely affected to this point. In Europe, the EBMT has established a registry of patients, and they're accumulating patients rapidly, I think, but we haven't seen any of the outcome or even descriptive data yet from that registry. And then here in the United States, we are working with the Infectious Disease Special Interest Group on putting together a database similar to that, where we can just see what's going on a national level.
Thanks, Alpana. And so let me consolidate a few other questions here. Are we limiting transplants? I think we addressed that, all of us. Yes, we are. I think one of the questions pertains to how are physicians handling clinical trials during this time and prioritizing and the precautions in patient education. I can answer that. I can say at our institution, as of this Monday, almost all clinical trials have come to a grinding halt, except for those where it's considered life-saving. For example, a transplant or no transplant, then of course the patient would be on the trial, and or those which involve oral medications that could be delivered safely, particularly if those are in the outpatient setting. I think those trials are ongoing as well. But most of the trials, including the several CTN trials, with the exception of one, have all been halted, at least for now. Right now, they're all halted through the third week of April, but who knows how this is all going to shake out. I hope that sort of gets to the answer in the sense that those are in halt. We are not allowing our coordinators to, I mean, the idea was to minimize coordinators' exposure as well. And with the number of deviations coming to bear, I think it just reached, at our center, we have really closed down a lot of clinical operations to take care of COVID-19 patients. So that's obviously affected our ability to use infusion space and other things. So it's really come to, I would say, a more or less a grinding halt. And some of these questions we won't have time to answer. I think we only have like 8 minutes to go. So let me quickly try to answer as many as we can. But if you can keep sending the questions in, then we'll try and answer them or perhaps in the second webinar, or we can answer them through emails, or if there's a chat room or something, we could put them there as well. So let me ask you, Roy and Alpana, a couple questions relate to CAR T cells. One is if the use of tocilizumab for CRS, just given the shortage, are there any alternatives for tocilizumab in CRS patients who are receiving CAR Ts and other cell therapies? And a second question around CAR T cells is, are the concerns, any specific concerns for CAR T cells that are unique and different from transplant? And are CAR T cell infusions being delayed at your centers? Roy, if you could take a crack at those two questions, and then I can tell you we are delaying CAR Ts, especially it's all patient-centric. If the patient has symptoms, we are definitely delaying it, but otherwise we are, and all elective CAR T admissions are being delayed. Elective is a relative term I'm using here at this point, particularly for things that are lymphoma, where we don't think it's exploding and things of those types of diseases. But Roy, can you take a crack at those two for tocilizumab, for CRS, alternates for tocilizumab, or Alpana, you can chime in as well, and CAR T-cell delays?
Right. So yeah, we also, if you can delay, then this is always, rule of thumb that you delay anything you can, if you can, either transplant or CAR T. But we still have ongoing CAR T cell infusion, and what we decided internally to test patients before infusion. So we're doing COVID-19 testing on these patients, a small number for now, because we're trying to either delay this kind of therapy. Tocilizumab story is, it is in shortage, and we were pretty cognizant of that when we developed our management guidelines to use it for COVID-19 patients with the RDS, or right before having severe pneumonia or severe lower tract infection. But with something to keep in mind that you may not be able to find enough tocilizumab for either CAR for CRS or for the COVID-19 patient. So we keeping a track of usage and try to acquire more. I'm not sure about alternative therapy. I will leave it. I don't know if Alpana has any answer on that.
No, we haven't really thought about the shortage issue specifically for CRS quite yet, but I think it's a good consideration as we consider which patients to use TOCI in.
Yeah, and there is a talk about anti-IL-1 for the COVID-19 patient. In theory, does it work or not? We don't know. I don't think there is clinical experience, published clinical experience for COVID-19 patients. So going to anti-IL-1 instead of anti-IL-6 in these patients with COVID-19.
Yeah, that's a great thought about anti-IL-1, but as you point out, there's really no certainly clinical data or experience around that in this particular situation. So Roy and Alpana, I think one final question for all of us. I'll try and club two of the questions together. One of them is, I think an important question is, what about patients who potentially could go back to group medical homes such as Ronald McDonald House is one question, and a part of a question. And then the other question is, if COVID-19 is spread through respiratory droplets produced by infected person, how can someone be contagious before they are symptomatic? I think both of you can chime in, or one of you can chime in. We are just really running short in time here.
I can take further the question about the transmission. What we know is it's a droplet transmission. Now, and you have to be coughing, sneezing usually. It increases the risk of transmission. This is probably in 98% of the time or 95%. No one really knows, but this is the most common route of transmission. Now, if you're asymptomatic and not coughing, not sneezing, how this is happening, I don't know. I don't think we have the answer. I'm not sure really if asymptomatic patient can transmit the virus unless maybe very close contact, or maybe they are already symptomatic and with very mild symptoms, a little bit of cough or something like that, then they can transmit it. There's lots of talk about it. Unfortunately, that's what's creating lots of concerns and maybe panic about this asymptomatic transmission. But keep in mind, is this still very uncommon in my mind, like other respiratory viruses, even with this one. It is not the main route of transmission. You have to have cough, sneeze, and symptoms.
Alpana,
I agree with that. I was just going to tackle the other question about group homes. I think that it is definitely something that we're thinking about and worried about, and we are considering actually changing kind of our this may not be the case for every center, but as a referral center, we do have people that come in and need to be close to the clinic. And I think like 30 minutes or something is our rule for standard situations. So we are thinking about making some exceptions to that to allow more people to stay home and not be in these group living situations.
Fantastic. I think we've run exactly at the top of the hour now, 4 p.m. Kara, do we have a minute or do we need to wrap up right now?
We do need to wrap up. I want to be respectful of everyone's time. I did want to point out we do have posted a few resources on this slide, and these slides and the webinar recording will be shared, so you'll have access to these links. The ASTCT has set aside a special space on our website for the COVID-19 community where we can post discussion questions. So for whatever reason, if we did not get to your question today, please utilize that as a resource to post your questions and get some feedback from peers in the field. In addition, there is a learning network dubbed Talent that has a very similar goal of trying to communicate better with peers on best practices as it relates to COVID-19, as well as the links to the CDC COVID-19 information for healthcare professionals. So all of these resources will be made available, and you can access these links when we send out the slides a little bit later. I want to thank you all for attending. I've put our contact information here. If you have anything that you need to reach out about, you can also access that community page on our website and reach us on social media through Twitter. Thank you so much, and especially thank you to our presenters today for sharing your expertise. It was a wonderful presentation. I wish you all luck and have a wonderful afternoon.
Thank you.
Thank you all. And for those whose questions didn't come through, our apologies. I think we missed a couple of questions that were sent in early, but hopefully we covered the gist of those questions in the earlier discussion. Thank you all, and particularly thank you, Alpana and Roy, for joining in, and thank you, Kara, for the fantastic support.
Thank you.
Thank you.